Hello, everyone. It's the top of the hour, so I think we'll go ahead and get started. I want to welcome you to the fourth webinar of a six-part series on opioids in the hospital addressing inpatient harm. My name is Michelle Bonson, and I serve as a clinical quality consultant on the Compass HIIN team. For those of you on past webinars, welcome back. And for those joining for the first time, thanks for joining us today. The goal of this particular series is to provide all of you with standardized and evidence-based approaches to reduce inpatient adverse events related to opioids. Today, we will spend our time identifying gaps and setting goals to close those gaps. We have a couple of brief housekeeping items to cover before we start our session this morning. I apologize, it's kind of like a broken record for most of you who have joined every webinar, but we want to make sure that you take a moment and check your phone lines or computer audio to make sure you are muted. We appreciate your attention to this as it does help us avoid some background noise during our session. We also ask if you need to step away from the session today, please avoid placing the call on hold so we don't have your call waiting background music playing during our webinar. We expect that you will have questions as we move through the session, and I will actually be asking you questions as we move through the session. I want to encourage your engagement. Please utilize the chat box throughout the webinar to type in questions as they come to mind. And if you haven't already done so, please take a look at your chat box to make sure that you have selected all attendees and panelists. So there's a 2, and then you can do all panelists and attendees. This allows everyone to see what comments and questions you might be submitting. I'm going to pause for a moment to make sure you all have it set accordingly. If you would like to speak during our webinar, please utilize the raise hand symbol and we will unmute your line to allow everyone to hear you. Lastly, this session will be recorded and transcribed. Prior webinar recordings can be found on the Compass HIIN YouTube channel. The location is noted on the footer of this slide. Before we get things underway, let's take a few minutes to go over the agenda. We will do a quick intro to see who's on the call, go over a few announcements, briefly recap webinar 3, tag on a bit of content that we didn't cover last week relative to interventions when a patient experiences excess sedation and or an adverse event. We'll move into action or taking aim, which includes identifying gaps and setting goals to close the gaps, and then close with next steps. For your convenience, a link to today's presentation has been added to the chat. I think that Lexi did that for us, so thank you very much. I hope that you can access that readily. Looks like, Tanya, you don't have the printouts for today. Where can you go to print off the slides? Are you able to see that link that Lexi put in? Oh, thanks, Dino. Appreciate that. Okay. I think we're all set. I had the opportunity to introduce myself. Okay. Oh, hi. Hi, Delilah. Thanks for joining us. I will try not to call you Tanya. I appreciate that. So I introduced myself, so take a few moments to type your name, organization, and role, and your title, and what your plans are for the upcoming holiday. And can you guys believe that we are coming up on July? I just can't even understand where time went. Seems like I was just complaining about snow not too long ago, and here we are going to be heading into July. So go ahead, take a few minutes, introduce yourself. Thank you, everyone. It looks like people have some great plans, include water and family and camping and everything that we want to do in the summer, right? So just by way of background, this photo in the slide is actually from fireworks in Des Moines. And if you've never had the opportunity to participate in that, I have to tell you, it's absolutely wonderful. It might be enhanced a little bit, but I sure enjoy it. As previously indicated, this is the fourth of a six-part webinar series. We won't meet next week, but we will gather back together on July 10th. Portions of this series may be comprised of a mix of presentation and work time. In other words, there may be an early dismissal prior to the top of the hour to allow you additional time to absorb the material, take a closer look at the information associated with the embedded links, and to begin your homework. It seems like we always have homework, which is great. We want you to take action as part of your participation. Let's do a little bit of recap regarding what we covered last week. During that session, we spent the hour reviewing best practices in the hospital setting that result in less patient harm related to opioid use, and those included screening and risk stratification, safe prescribing and administration, the importance of monitoring, and education, both as it relates to staff and patients. That time was well spent, as evidenced by a study performed by ECRI, which found approximately 1/3 of adverse events involving opioids stemmed from errors in administering opioids during a hospital stay. Those issues included problems with administering the wrong medication, the wrong dosage, or inadequately assessing the patient for potential adverse effects prior to giving them an opioid. As evidenced by the quote on the slide, you can see that 20% of those events resulted in harm due to failure to monitor or track sedation level. So I think all of those best practices really align well with what ECRI has found. I wanted to be sure to follow up on a request I received last week relative to sample pain policies. The links on this slide will take you to various policies that you may refer to for ideas on content for your policy. These are samples and as such not endorsed by anyone outside of the institution in which they were written. That's my little disclaimer there. I was not able to connect with Brooke before our webinar today, so if anyone else on the call has a sample of a pain management policy they would be willing to share, please let us know in the chat or feel free to contact me directly. Last week, we didn't have time to delve into what we should do when all safeguards and best practices have been put into place and yet there is failure or error. So today we'll talk about a rapid response system and the use of naloxone. Rapid response systems are not new in concept. They were created to improve recognition of and response to a patient's deteriorating condition or conditions in all areas of the hospital, and in an effort to decrease hospital morbidity and mortality. These were developed before the onset of the opioid crisis, but are well suited to incorporate opioid-related adverse events and excess sedation. The three arms of the system include criteria and a system for notifying and activating, which is also referred to as the afferent limb. There are typically criteria set for identifying deterioration, including vital sign abnormalities, changes in mental status or sedation concerns relative to opioid use, or other significant concerns about the patient's clinical presentation. These concerns may be expressed by a nurse, a physician, or a family member. I think this is further testament as to the importance of patient-centered care, teach back, and equipping the family with education and knowledge about the care of their loved one. Patient and family engagement is a constant theme across the care continuum, and the momentum is not changing. Okay, I'm going to step off my soapbox a little bit about that, albeit a very important one, and I'll get back to RRS. A response team, or the Afferent Limb, may include medical emergency teams, rapid response teams, or critical care outreach teams. The next slide provides examples of the makeup of these teams. Regardless of the team structure or configuration, individual unit managers, possibly referred to as unit managers or a nurse manager in your organization, who make regular rounding on at-risk patients may add a layer of familiarity and increased likelihood of identifying even the most subtle changes that would indicate eventual decompensation. Quick question for all of you, and you can answer using the chat box. How many of you utilize your nurse managers in this capacity? If you don't do that yet, what are your thoughts on incorporating it? Is there a current standing rounding protocol that you could leverage? Great. I see a couple of responses coming in. Barb Engel, would you just take a moment and make sure that you have selected all panelists and attendees for your chat? I'm able to see it, but others are not. So we have a couple. So for those of you that aren't using that process, do you think it would be something that you could leverage or incorporate? I think it's a really good practice, and I would encourage you to think about that as you sort of work through this jumpstart and opportunities for improvement. Last but certainly not least is the importance of collecting data, analyzing data, and providing feedback that should include informing leadership on opportunities to coordinate resources and what is needed for ongoing sustainability and or enhancement over time. There are several models proposed for rapid response systems, and this slide represents one put out by ARC. When excess sedation or respiratory depression complicates care, patients require evaluation for a higher level of care, which would equate to possible transfer to a higher level of care either within or outside of your walls, depending on the acuity and your ability to manage that acuity. So you can see on this slide that, a medical emergency team may have physicians, critical care or hospitalists and nurses, and what their duties are to respond to emergencies. And then there's also the critical care outreach and the rapid response team. And the rapid response team has different personnel. However, their duties are very similar to that of a critical care outreach. And included in this slide is a link to additional information on this. While there is evidence to support the use of a rapid response system, you may hear or read that the effectiveness is not proven or at best controversial. Experts suggest that this may be a result of untimely calling and activation of the rapid response team due to the following. So there's self-efficacy. A person must feel as though they have the necessary skills and abilities to act, even in the face of barriers or obstacles. Staff need to feel confident in recognizing clinical deterioration, particularly when it relies on a thorough clinical assessment in order to recognize and activate the RRS in a timely fashion. Hierarchy does come into play. Let's take a moment to be honest here. Hierarchical norms among nurses and physicians exist and unfortunately contribute to untimely activation. A nurse may seek approval from someone above them before pulling the trigger. The same is true for family members and other healthcare professionals that are subordinates to the nurse. Breaking down this barrier requires a significant shift in culture and strong leadership support. We all know that past experiences and perceived perceptions impact us, and they're really hard to shake. Perhaps being ostracized versus educated, yelled at versus conversed with, feeling like you aren't good enough or that you provided substandard care results in fear and self-doubt. And now we're back to the self-efficacy and hierarchy. So I think it's just really important to think about how these impact a delay in activating the system, and ways that you could go about addressing those might include working with your staff, understanding what their concerns are, sharing those with your leadership, getting some leadership assistance, and making sure that these things are addressed. We can't end our conversation on RRS in a negative note, so let's talk a bit about some key points for success. RRS should be a part of your opioid safety program and serve as an adjunct to risk assessment, the safe prescribing and administration of opioids, and continuous monitoring of patients who are receiving opioids. Assuring your organization is prepared to respond may be more important than who responds or what criteria triggered the activation. Now, I say that lightly because without both, you will likely be unsuccessful. However, it is likely that quality plans and organizational buy-in trump structure. Finally, data, continuous QI, your culture, education of your staff, your families and your patients may be the most important, not only for RRS, but to all things in the healthcare delivery system. There is a lot of material, references, and resources on RRS. Included in this slide are a couple of websites that you may find helpful in your work in this area. Before we move on, I'm going to pause for a moment to see if we have any questions or comments. Okay, I'm not seeing any at this time, but feel free to drop some in there anytime that you have them. We're going to move into talking a little bit about naloxone. Remember when naloxone used to be a drug most familiar to those practicing in a clinical setting? Times have changed relative to where it is obtained, when and where it may be administered, but the intended action and appropriate use has not. In our very first webinar, we spent a great deal of time reviewing the HIIN measure, inpatient stat naloxone administration. For your reference, links to the HIIN measure set and toolkit are included in this slide. In the event your past data was not in alignment with the numerator and or denominator, please reach out to your assigned clinical quality consultant for assistance with data correction. Examination of naloxone events may be useful to uncover opportunities to improve opioid safety. A root cause analysis or other mechanism by which you can identify and isolate causative factors and then look at those factors collectively is a best practice approach. I would recommend reviewing and analyzing as close to real time as possible, allowing for identification of immediate remediation and short to long-term process improvements. Let's take a look at some of the things you may want to include in your examination of naloxone events. Was there improper prescribing and or administration of opioids? And was there improper prescribing of and administration of multiple opioids? For example, parenteral dosing and inappropriate use of long-acting opioids. Does your staff have a lack of knowledge about potency, differences in opioids? Was there pharmacy intervention or recommendation involved? Was the patient sufficiently monitored for sedation? We talked a little bit about some of those monitoring tools at our last webinar. Was there excess use of or were there other sedating medications such as benzodiazepines accounted for in the management of the patient's pain? Was there any assessment for opioid tolerance or naivety prior to the administration of the opioid? And was there any form of medication reconciliation prior to or at the time of admission? Talked about that at our last webinar too when we discussed best practices. And here's another key one. Was there an opportunity for pain control outside of opioids. Think back to the comfort menu and educating and engaging the patient in pain management decisions, and to opioid sparing options such as multimodal analgesia. So, using the chat box, what else might you include in a root cause analysis that is not on this list? Fire away, guys. We have a lot of participants today. I'd love to hear from all of you. What else might you think about when you're looking at the appropriateness of the use and the response to opioids, particularly naloxone events? I'm not seeing anything in the chat box, so I will add a couple. Oh, here we go. Hi, Sandy. Sandy would want to know if the patient is opioid naive. Great. Absolutely. I have a couple for you to think about. One is the appropriate use of naloxone. For example, was it indicated? What were the presenting symptoms and rationale? And was the RRS, if applicable, activated timely? And was naloxone administered? So that might sound kind of strange, but we have found occasions in working with our hospitals when naloxone has been dispensed but not administered. So when you are getting reports from your pharmacy and you're looking at naloxone, you may be seeing that it was actually dispensed, but it wasn't administered. So it's important to capture the actual administration in an effort to monitor opportunities for improvement. Oh, I love that one. And I know it's not Tanya today, it's Delilah, but I love it. If there's an operative situation, was there adequate education and realistic goal setting? That is huge. And that's where we get the patient involved. And it's where we have those conversations about pain and how they want to manage their pain. So that was perfect. There are various guidelines available for references as it relates to naloxone administration and patient monitoring. Here is an excerpt from the linked protocol found at the bottom of the slide. I would encourage you to review the entire document for reference and benchmarking with your protocol. There's another one I'd like to share with you, but what I'd like to point out is that there are some key things that you should be looking for or have set in your own criteria before naloxone is administered. In this particular guideline, they're looking for someone who is difficult to arouse or there's no response to physical stimulation, shallow respirations, what they equate at a rate of less than 8, and then also pinpoint pupils. And so these are just some things that I saw across a couple different guidelines. I would encourage you to work with your team to determine what your guidelines should be and what are your criteria. This one also goes on to talk about the patient assessment if hypoventilated and depressed mental status are suspected, and it kind of goes through the various steps. I know this one is itty bitty. It's actually very, very difficult to read, and I apologize. I kind of put a magnifying glass on there trying to make it look better. But the entire guideline can be accessed using the link in the slide. This one, like the other, speaks to the various criteria with a caveat that there may be documented exceptions to the criteria based on physician assessment and clinical judgment. I think this is a good time to throw out a disclaimer regarding the two guidelines I've shared. These are not guidelines that I suggest you take and implement as they are. They are meant to serve as a benchmark for your own in-house guidelines. And if you find that they meet the intent of what you want to do, they are accessible and you may use them. But again, I would suggest that you use them as a benchmark. At a high level, each of these has an assessment for possible opioid overdose, ways to manage it, including stopping administration of the opioid and benzodiazepines if they're present, maintaining IV access, using oxygen, getting assistance so you don't leave the patient alone, administration of the naloxone, including dosing, frequency, and titration, and soliciting assistance from a rapid response team as needed. How many of you have standing orders built in for the use of naloxone and monitoring in your acute care units? Go ahead and use the chat box and share with the group if you have those. Thanks, Joni. I'll be interested to see what you find out. And that may be the case for several of you on this call, depending upon what your role and responsibility is. Great. Delilah says, you do not have standing orders for use and follow-up when giving naloxone, but this would be a great intervention. I agree. It's a best practice, and so that's what we're all about here. So that might be an area of opportunity for your organization. All right, you guys can kind of noodle on that a little bit, and we'll continue on. In webinar number 2, we reviewed the environmental assessment, and a tool was provided to assist you with taking inventory on your current processes and or your procedures in place as it relates to safe opioid use in the hospital. That, combined with last week's presentation on best practices and the first part of today's presentation on managing excess sedation, provide you all with some good framework for deciding where to look for opportunity and react to that opportunity by doing something. Each of you will have your own ideas on what you'd like to do with the material we've been reviewing, and my hope is that it moves beyond education. I think education is really important, and so if you're gaining additional education out of this, that's fantastic. For those of you that are administering naloxone, how about a root cause analysis to determine if there are patterns you can isolate, or if not a pattern, perhaps a big aha? For those of you who are not administering naloxone yet, how about a review of your current order sets, tools, and protocols around managing opioid tolerant versus opioid naive patients, or how frequently staff monitors patients on opioids, and is it performed according to your according to standards and documented appropriately. Think about how to reduce or avoid harm for patients prescribed and administered opioids in your hospital. Given that we will have an extra week of work time built into the series, what are some initial ideas you have on what you might do next? Just going to pause for a moment here. I think Joni already said she was going to kind of check in to see what they had around naloxone administration, and Delilah, you also said you didn't have standing orders, but you might look into that and see if that might be a great opportunity for your organization. What about the rest of you? Are there any sort of gaps or things that you've thought about as we've gone through the last several weeks about opportunities? And I just want to take a moment to remind you, If you'd like to speak, feel free to raise your hand and we can unmute you. Some of you may prefer that. Okay, I'm not seeing anything in the chat, so I will offer up a couple of ideas that you might want to think about in addition to the things that we already talked about. I think there's a plethora of options, but one of the things you might want to take a look at is patient and family engagement. Where do your patients and families fit? Learning about the PMP and the part it plays in appropriate risk management. That's something that I think some hospitals are starting to do in their ED. Educating staff or doing staff audits relative to the protocols is an idea. Using your internal data, perhaps you have averted or avoided alerts in your EMR. Kind of talked a little bit about alarm fatigue last time. Maybe developing an opioid guardianship program that incorporates not only opioids addressing the opioid crisis in the ER or in the community, but incorporating that inpatient piece. And Delilah, it looks like education, education, education for all staff and emphasis on empowering families, how they know their loved ones better than we do, and standing order for giving Narcan. It will speed up the time. Perfect. And then the last thing is a pain management organizational compact. I'm going to talk a little bit about that. This is something we have not talked about. I've stressed the importance of having leadership to care delivery staff involved in order to be successful in not only reducing opioid harm, but reducing harm in any domain. The Institute for Healthcare Improvement recently put out a toolkit regarding advancing the safety of acute pain management. And I love this toolkit, by the way. It's one of the things that I've sort of been referencing as we've gone through several weeks, but I encourage you to really take a look at this because there are several pieces of information that I'm going to spend a bit of focused time discussing, but there's a lot of other information that you might find helpful. The first thing I'm going to talk about is the Pain Management Organizational Compact. This particular compact clearly delineates the expectations of leadership and clinicians and staff as it relates to management of acute pain. I think it represents a good balance to make sure objectives are met. It's kind of small perhaps on your screen, but just know that you can get to it by using the link below. And one of the things I really like about this is it represents a good balance to make sure objectives are met. And I'm a Libra, and as such, scales and balance are important. You're probably wondering why it's there. So please don't think that you need to be a Libra to appreciate this concept. It's just something that came to mind as I was putting this together. Using the chat, do you think this may be a good tool or starting point for your organization to determine if things are balanced? And have you ever utilized a compact like this for other initiatives? If so, how was it received? So of course it wouldn't be around pain management necessarily, but maybe something around readmissions or ADEs that are outside of the opioids. Or maybe it's something it may be pertinent to other areas. I'm just curious to know a little bit more about if you've ever seen anything similar to this or utilize something like this. Joni, thanks. It's very interesting. You're saying. I don't know if you wanted to add a little bit more to that, or if you just think it's interesting and you're going to plan to look into it further. We've covered a lot of ground the last 4 weeks, haven't we? It feels like we've really taken a deep dive into this inpatient harm related to opioid use. So given this, I thought it might be helpful to provide some additional tools from the IHI paper to assist you with identifying areas of opportunity. This cultural assessment allows the evaluator to determine if a particular objective is met, and if it's not, allows a rating as to whether it is of low priority or high priority. Variability in responses is expected depending on the type of hospital and the services provided. And if I didn't say so before, a link to the entire IHI tool is embedded in the footer of this slide. And one more thing I'd like to point out, the culture ultimately dictates the action. If you don't have the culture to start working on these particular areas, perhaps you need to take a step back and determine how you might be able to change the culture. I would recommend using your data, citing regulatory requirements, and or providing evidence-based data that shows how increased costs, both financial and even possibly reputation, occurs when opioid harm is not addressed. And you can always refer back to the first webinar that we had, which is posted out on our YouTube link, and the materials that were sent out, because we did talk a little bit about the expense to the hospital or the excess lengths of stay and things that happen when we have opioid overdose in the hospital. Much like the cultural assessment, this IT assessment allows for evaluation of the availability and flow of readily available information that improves patient safety. So as you will see in the last two assessment worksheets, there is an ability to rank priority, which is extremely important, because if everything becomes a priority, then, and I have a little ... in my notes here, using your chat box, write what you think happens if everything is a priority. If you're trying to do everything, what happens? I know my teammates have heard me probably say this. Kate, you've heard me. Yes, Joni. You're exactly. It gets ignored. It gets lost in the shuffle. It's really hard to do everything, and actually, it's not possible. Nothing is a priority, and you end up trying to boil the ocean. And we all know what happens when we try to do that. So don't try to boil the ocean, right, Sandy? You fail miserably. So just a gentle reminder to you all. There's so much to do. There's so much opportunity, but just take a little piece. I'm reading what Delilah posted in the chat. So feeling like the push to fight against the opioid crisis has led to practitioners not ordering opioids when it's appropriate. It's really hard to balance controlling pain and being on road to recovery after a surgery and preventing an addiction. Education is the key, but you've heard patients, in particular, a patient with chronic pain who's on daily opiate regimen or regime, who is concerned with not having adequate pain control after, say, a surgery. Yes, it's complicated. And you know what, Delilah? We talked about that a little bit, and that's sort of having, if there is a planned admission, that's part of the pre-admission checklist, I would say. And if it's not a planned admission, it's really important to work with those who are opioid tolerant. And we talked a little bit about that as well. It's important to not to stop prescribing their opioids, because it may send them into withdrawal. And so if there are a lot of resources available regarding that, and we did discuss some of those within our recent webinars, but I would be happy if you had any specific questions, feel free to reach out to me. Delilah, I'd be happy to help, or any of our clinical quality consultants would be able to help as well. Yeah, 180 degrees from your hospice or palliative care days, yes. Yeah, and you know what? The providers are probably going to decrease prescribing opioids because of the legislation that went in last year. There are there are pretty significant requirements about accessing the PMP. Providers are actually getting provider specific reports on their prescription patterns, and they're able to do a comparative analysis to like specialties. I'm trying to think of some of the other things. A lot of that was sort of geared toward the outpatient, but it is applicable to the inpatient. And I think that just really engaging those families and those patients about what other things might help them through their pain, and just having a very upfront, candid conversation about it. My mom was recently hospitalized, and even in the critical care unit, the nurse, who was excellent and was doing great teach back, and was talking about how they manage opioids within the hospital and what my mom could expect, and sort of how they would start out and what their was and their tapering protocol and those sorts of things. And so they really put it in my mom's hands, on how to best manage that, and it was also discussed prior to her admission for her surgery. So she had a lot of ability to sort of direct that, and I think that's really important. So again, we're back to education, aren't we? I agree with you, Delilah. Pre-surgery education is optimal, but I think that they do need to know that they you are going to support them and help them manage their pain, help them be at a functional status that is appropriate for them, and that there is pain, right? I mean, that's one of the key things. I think we always were so focused on absolutely zero pain, and I don't think that's the reality. I think there's always going to be some degree of pain, so helping them understand that is important. I think you're hitting the nail on the head there. Lastly, let's take a quick look at the process of the root cause analysis. After this presentation, I would recommend that you either utilize the links in this slide or refer back to slide 15 to create your own RCA for opioid adverse events. Please remember to include appropriate use of naloxone. Was it indicated? What were the presenting symptoms and rationale? Was the RRS, if applicable, activated timely? Was naloxone even administered? So I guess that kind of doesn't make sense because the root cause analysis would be around naloxone administration. But if you're looking at a report that you're getting from pharmacy, perhaps that's identifying whether or not naloxone was administered, I kind of have air quotes here, it might be an opportunity for you to determine whether or not it was administered or if it was dispensed. And we really want to make sure that you're looking at those particular patients where it was administered. Adding these things will allow you to have additional facts when evaluating your incidence and or prevalence related to inpatient naloxone administration. Here are some references for today's webinar. Other references can be found in the footer of slides as applicable. Okay, I know it's bad, but you might be chuckling a little bit, I hope, bringing a little humor to your day. All kidding aside, as we prepare to wrap up our time together, please enter any questions or comments you have in the chat box. I'm not seeing any. We've really covered a lot of information, and my hope is that you don't have information overload and that you're really able to sort of pull out some key ideas or pieces that you would maybe want to work on. So please utilize those checklists that we talked about previously in this presentation. I think it'll be really helpful. I want to thank you for your time today. We're wrapping up a little bit early. You will receive an email with links to this presentation. You will see that your homework includes identifying a gap and creating a goal, and be prepared to share when we come back together on July 19th. I really, really want to hear from all of you. I want to hear that you're gaining something from participating. I want to hear that you are thinking about things that you want to do within your organization. I know several of you have shared today, but I would love to hear from the rest of you. And because we will be discussing, implementing, and evaluating interventions on July 19th, I would ask that you come with one or two interventions that you're sort of thinking about that align with your goal. And maybe if you're an overachiever, you might have already thought about your gap that you want to address, thought about a goal, and maybe you have a couple of interventions that you're testing in a particular area. And I think that's absolutely wonderful. So please be prepared to share those. And if you have any questions prior to the next webinar, please feel free to reach out to me or your assigned clinical quality consultant. And I hope you all have a great week and a great holiday. And I hope that it's safe. Talk to you all in a couple of weeks. Bye.